starting the project, we were offered to choose brain tumors as a model for the health and child study, and we didn't know exactly what disease was the best to choose. We decided for gliomas because they are the most frequent brain tumors in childhood, and also because despite the fact that they are the most frequent tumors, there are several questions still open in their treatment. But you can see from this slide that after gliomas, we have the a lot of malignant tumors like medulloblastoma, ependymoma. These tumors, the tumors are very well known, more known than gliomas. So that's why we decide to, either for the frequency and for the fact that there was something to study more. Pediatric gliomas, anyway, is not only a very defined disease, it's a group of tumors originating from glial cells, which are cells that are surrounding neurons, neural tissues, and they may have different functions in the brain, in the normal brain. Prognosis and treatment options depend on histology, location of the tumor, child's age, association to genetic syndromes, and such as neurofibromatosis. Neurofibromatosis is associated to gliomas in 15% of cases. And the staging, which means if the disease is localized or if there are metastases, is disseminated. And then again, when we have to decide how to treat the patient, we need to look if there is the prognosis, and so then the possibility to be cured depends on if the tumor has been operated completely, removed completely, or if this is not possible, and or if there are other sites of disease. So when in the multidisciplinary approach, we have to decide which treatment strategy to use. Nowadays, we need to keep in mind that we have several treatment modalities like surgery, chemotherapy, radiation therapy. In certain cases, when we are not sure that the tumor benefits from our treatment modalities, this happens in case where the tumor is very small, a slow-growing tumor in a difficult site, and because chemotherapy and radiation therapy sometimes are related to side effects, severe side effects, or surgery is not possible, we adopt a strategy of wait and see, so we can perform more than one control at MRI and decide later on what to do. And so, but in the 20 and 30 years ago, we were deciding about treatment strategy more on site and histology of the tumor. Now we are keeping in mind that we need to have as objective of our treatment either survival, but also quality of survival. So, so we know that radiation therapy delivered at a child less than 3 years of age may be associated or related to the risk to severe late effects like endocrine dysfunction, neurocognitive changes, and so now we know that we cannot offer radiation therapy for children less than 3. So we have to keep in our to account in our treatment strategy consideration also age. And again, we know that when the gliomas are associated to genetic syndromes, they may have an indolent behavior, they may behave differently, and so we may choose strategy of wait and see when there is, let's say, a neurofibromatosis or other genetic syndrome associated. But again, all the factors that I have mentioned are not satisfying yet. What could help better in give a treatment more tailored to the real need of the patient could be to have more information on tumor biology. Because tumor biology is really the one which can influence the response to treatment, the outcome of the patients, etc. So that's why we especially in the last 10 years, we had a lot of more information coming from neuropathology advances, biology advances. So now this schema of treatment strategy is becoming more complex, and we needed to correlate more genotype to phenotype of our cases in order to get a more personalized treatment. Going back again to gliomas, if we say the first prognostic factor considered in treatment strategy is histology. But as you can see from this slide, gliomas are not only one unique entity. There are tumors with that have a different label. So gliomas include the tumors that are composed by pure astrocytomas, and so the tumor originating from astrocytes, and that they may be either malignant or benign, which means benign from grade 1 to 2 and malignant from grade 3 and 4. Grading of our tumors is indicating the malignancy. But we have a second group of tumors of the gliomas family, which are composed of 2 or 3 even sometimes type of cells that we may have astrocyte mixed with neurons. So we have mixed gliomas. These tumors have a more unpredictable behavior, and they may be graded with a variable grading, and sometimes the degree is not very easy to be defined by the pathologist. Again, there are also tumors where grading is not possible. So that's why also, because this variable grading and some difficulties in a certain type of tumors, that we should have more information on biology in order to have more precise marker or of behavior of the tumor.